model, a circular model, okay? I think it's core competencies or something, which coach uses, but I can't quote you their specific definition. Okay? And there probably is no consistent definition anywhere yet around the world as to what exactly it means. Okay? We are a semantically challenged field. We are a semantically challenged field. Alvaro.
Related to that, Dennis, bioinformatics also.
Bioinformatics,
too, right?
that's, that one I am going to mention. I think, in fact, Alvaro, I think it's the next slide. No, it's coming. E-health. This is a phenomenon of how we use words and how we describe things. I don't think any of you are old enough to have lived through the early days of the use of computers. And what was the term that was used when computers first started being used in the 50s and the early 60s? Anyone happen to know that little historical tidbit? It was called data processing. Data processing. And then that changed to electronic data processing, EDP. So if you go back into historical books, and you'll find it started in the private sector, eventually showed up in hospitals. It was data processing. So one of my early jobs, one of my very first jobs, was a director of data processing, way back when. We then got sophisticated and we said, well, that's not good enough. So we, the industry, all of a sudden started talking about computer systems. And that didn't last very long, where we started now talking about management information systems. Okay, we went through that period of management information systems. And in healthcare, we started talking about hospital information systems. And I've always argued that we made a huge mistake when we started introducing the word information. We should still be using the word data processing, because that's basically what we were doing. And I don't have time to go through my lecture, but there's a difference between data and information is not what's in computers. So then we went through hospital information systems, and then we went through another stage. I'm missing one. Anyways, we went to electronic health records. All of a sudden, everything was electronic health records. We dropped through in hospital information systems. And now, of course, we're now into the e-health era, where so much is e-health, okay? And that's another one that we're having difficulty finding consistent definitions as to what do we mean by that word, okay? And Claudia has done quite a bit of it, and its origins started around the internet. And that's where the first notion of it came. The e-commerce portion started, and we picked up and went e-health. So we have that we have to throw into the mix. Now we've got a new term, yet another term coming called mHealth, which is now starting to surface. Mobile health, okay, to reflect the use of mobile technologies, okay. So that's something else that we're struggling with. And as Alvaro said, the one that's the explosion coming, and I will be retired, and they will have to deal with it, is how we're going to deal with the genomic data. The explosion that's coming with genomic data, genomic and proteomic data that's going on, which at the moment is sort of falling under the umbrella of bioinformatics, biomedical informatics. I mean, some of our American colleagues are changing their programs to biomedical informatics, away from medical informatics to biomedical informatics, and naming their schools. And I think in part it's because there's large amounts of government funding available for this side of the field. Okay, and I think some of them are changing their programs to reflect that and get the government funding to support their programs. But that's a huge wave coming down the pipe, which I don't think anyone really has a grasp. Did one of you not write a paper about that?
Yeah.
You did. So
Yeah.
give us a little insight as to what's coming. Quickly, Richard.
What's coming? I think what we're gonna have to do is we're gonna have to change the way we're looking at diagnosing and prescribing for patients. We're gonna be looking at a person's genomic profile, seeing what the variations are within the gene, and then prescribing appropriate dose of that.
It's going to have all sorts of implications for our records too.
Exactly.
Does family history kick into this?
Most definitely, yeah. Family history plays a big part in that. But it's very hard right now because we don't have family history that goes back beyond this generation. So in Iceland, it's a little bit different. We can go back to 3 or 4 generations.
Yeah. But it also raises, like so much of the technology, it raises other issues. It raises social issues, and ethical issues as to how we use that kind of data. So, anyways, so what I guess I'd like to leave as a final message that regardless of what terms we're using, okay, as long as we keep in mind what are we really trying to do with all of this. Okay, what we're basically trying to do is to make use of technology to help people make decisions. Okay? That's what it's about. And the technology and the systems will provide the data. It's the individuals who will generate that and convert that to information and help them make decisions. And all sorts of kinds of individuals. Okay? Patients, families, supporters of patients, clinicians, managers of various kinds and their staff, researchers, planners, legislatures, all sorts of kinds. That's what we're basically all doing. Use the technology to help make more informed and better decisions. Okay? Fully realizing that providing good, reliable data, which an individual can translate into information, doesn't mean decision. Okay? That's a whole other process. Actually do something with that information in that case. But that's basically what it is, regardless of the terms we use. Okay, got that out of the way. Now let's go to the electronic records. Okay, this is to again try to help come to grips with the fact that we have, is that a power source or is that one of those wireless? That's a power source. I bought a little wireless thing. You go into a hotel and you've got your iPod and it only works on a wireless network. You plug the internet cable into this little box and the box creates a wireless network and you can use your iPod. Something like that into that. Okay. We've been using medical records for about over 100 years now. It's over 100 years. The unit record in St. Mary's Hospital. There's evidence of a hospital in the United States and a hospital in England about the same time, starting with the medical record. Unit record as we know. This little catchy little diagram from InfoWay is that we still today, for the most part, are still running most of our healthcare systems on paper. Most of our healthcare systems are still very paper-oriented. And that's not just in Canada. That's in many parts, particularly in our hospitals. Less so in our physicians, less so in our primary care physicians' offices around the world. They are much more using electronic records than the hospitals are, generally speaking, and much more so than we are in Canada. So 1935, that was the picture. Not much has changed. This is a colleague from England who's trying to get the message out in England that we just can't continue working this way. This is a stack of patients' records for one day for a physician to work with. practicing. They took that picture, they stacked up all the records that the patient, that the physician was going to work with that day, and that's what came out. And we have some things. If those of you who've seen this, it's a good reminder about what we're trying to do. Think of your bank. Teller writes your transactions into a paper ledger. You're told you get your money in only one branch because that's where your records are. You can use your bank card only in the bank machines at your own bank, if there's even a card. Your balance is incorrect because the teller's handwriting is incorrect. You're told to wait for 2 hours while your money is sent by taxi from the head office. You have to receive a paper paycheck every 2 weeks, which you then have to deposit in person. Think of your airlines. Each flight has its own booking agent that you can contact when you by phone. And for those old enough to realize flying 34 years ago, this is the way it was. Connecting flights cannot be booked in advance. Once you arrive at a stopover point, you wait until there's a seat available on the next connecting. No confirmed seating can be canceled at any time before the flight. Being handed a ticket that says this with no further explanation. Told you cannot have access to your flight itinerary without the pilot's permission. Public is not given any information about any flight mishaps because the pilot might be unfairly accountable. Okay, now, I mean, those are not intended to be thrown out in a flippant manner. They do reflect a lot of what our healthcare is, not just in Canada, in most parts of the world. And it's just a characteristic that, I mean, this whole booking thing, you know, the way in which we book patients. I mean, our healthcare system is not customer-oriented. It's becoming more so. My goodness, it's becoming more so. But it wasn't built for customers. It wasn't built for patients. It wasn't focused. It was focused primarily around our facilities. The healthcare system is around our facilities. Okay, so we don't have the same orientation to the way we operate in healthcare as other organizations in society do. It's changing. It's changing. When?
Do you think it's the lack of competition that's created this environment? Like both of those things, the banking industry and the airline industry, a lot of competition drove what we see in terms of the
There's definitely an element to that. There's definitely an element to that. Absolutely. When we started using computers in healthcare, there was no real incentive to use computers in healthcare. And one of the reasons there wasn't any particular incentive is that in the 50s and 60s and 70s, even into the 80s, there was no concern about costs, none. And the best hospital administrators of the day were the ones that would decide how big a deficit could they get away with without getting slapped on the fingers too hard. They knew the governments would pick up deficits, and they did for 30 years. 30, 40 years it went on. So there wasn't any incentives to automate, to build in efficiencies that the technology could allow, because the model of the day didn't. So there not only was no competition, there also wasn't an incentive to use the technology. That started to change in the 80s. And it's continually changing now, of course. And we now have stellar examples around the world, pockets of examples around the world where that's not the case. They run closer to like an airline runs. They run closer to like a bank runs. But unfortunately, they're just little pockets in various parts of the world. We still haven't seen it develop extensively in any country around the world. Ken Moselle, a colleague from the Vancouver Island Health Authority, shared this slide with me, which he's in mental health. So